So hi everyone. So just going to share a case that we have. We had recently, I was on weekend before last and I was quite busy. So actually I thought it might be nice to share this case with you. Right. Just gonna minimize this. Okay. So that was a term baby. Was born by emergency section. Mom was actually in labor ward, progressing in labor, and then CTG suddenly went off. Baby had acute fetal brady. They didn't feel a cord prolapse or anything, but they said they rushed for category 1 section because of non-recovering fetal bradycardia. So baby came out very floppy, pale, with no rest effort. There was heart rate though, but it was slow, not very slow. So baby responded to IPPV, with good chest movement. However, baby didn't have any spontaneous breathing. And the GA section was very quick, so it was unlikely effective from the GA itself. However, because of no spontaneous breathing, the baby was intubated. So during that time, they increased obviously the oxygen from air to 100% while bagging the baby, and noted lots of secretions coming out, although there was no meconium actually. So baby wasn't stained with meconium, and the liquor wasn't stained with meconium as well. So just baby intubated, SATs start to come up, 85 to 92, 100%. He looked very pale, so the team decided just to put a UVC and request O negative blood just in case there was any retroplacental bleeding or antepartum hemorrhage that they weren't aware of. And I was called to attend. So the cord gases were actually okay, 7.2, basic cis -6. And then they had the UVC accessed already. And then they've sent some bloods just to do a gas, and the gas was actually quite terrible. So 6.9, CO2 of 10, basic cis -15, and hematocrit was 45. So that was around probably 7-8 minutes of age. So they just didn't actually match the cord gas, and certainly the baby was appropriately resuscitated. So we said, okay, let's switch off the heater and see what's going on. So baby was connected to the ventilator in 70%, oxygen saturating about 94, 95. And then the Apgars was quite low, as you see here. So in NICU, baby was started on SIPPV with this kind of setting, saturation, as you can see, and these are the OBS. So the BP was 52/28, mean of 40. So systolic was borderline, although the mean was okay. Repeated gas slightly improved. Lactate started to, actually the first gas, there was a lactate in the first gas? No, so there was no lactate in the first. So this was actually the first lactate here, was as expected high, and basic cis started to slowly come down. Baby was passively cooled until we just get him sorted. Chest x-ray was white out with bilateral lung field. I will show you the x-ray in a second. So we decided to give surfactant, commenced initially on benzpen and gent, but because of the second creatinine was slowly creeping up, we changed that to Taxim. While the baby just been admitted to the unit and starting to get him sorted, we had another crash call for a 24-weeker who mom just delivered in the delivery room. And baby came with no kind of breathing, no heart rate, nothing. So we rushed over there. We left this baby in ICU, and we were quite busy actually with that 24-weeker who sadly passed away. So we came back to see him, and then this was the situation. So still ventilated in a significant amount of oxygen. Gas is still showing respiratory acidosis. and lactate has come down though. OBS, as you can see, he looked actually, she was a girl, looked more alert, with better tone and movement, and put a CFM on just to decide whether to cool or not. And CFM was, trace was normal, above 5, above 10, was good sleep-wake cycle. So we have criteria A for this baby: poor gases, low Apgars, and prolonged resuscitation. And the neurological state you can argue about, because if you assess the baby immediately on admission, probably she was still encephalopathic, and later on she probably improved. So I would say she was between grade 1 and 2, definitely not grade 1, and probably not grade 2 fully. So we decided just to cool after discussion with other colleagues. So these were the X-rays. The one on the left is the first one, and then we give surfactant. Was quite patchy opacification. I don't know if the baby aspirated amniotic fluid. There was no history of antepartum hemorrhage, so it didn't look like aspirated blood. No meconium, but baby really had loads of creamy secretions. Whether it's congenital pneumonia or aspirated amniotic fluid, probably one of these. And then subsequently with the lines in, and you can see still lots of opacification and right upper lobe collapse. So as I said, we started active cooling at 4 hours, lines cited, switched to high frequency difficulty clearing CO2. Initially went down on Hertz to 9, then 8, and FI2 still around 65. Arterial BP, again, lowish systolic, although the mean is fine. But what do you think about this BP actually? Fraser or Abhijit or Becky?
Looks like okay at this point of time. Mean of 47.
Yeah, for a term baby, the mean is fine, isn't it?
Yeah.
But what do you think about the components of the BP?
I think the pulse pressure, the pulse pressure is less. Your diastolic blood pressure seems on the higher side.
Exactly. So very, very narrow pulse pressure. And that gives you an indication there is probably diastolic dysfunction, isn't it? Because the heart is not relaxing well. And that's why you have high end diastolic pressure, if that makes sense. And we know that the mean, 2/3 of the mean is coming from diastolic. That's why the mean is high. So when you get a mean, which is okay, you just look at other components that can give you an idea what's happening. So that was the first clue for me about the blood pressure. Obviously, we didn't commence morphine initially because I didn't want to alter the neurological status and have a full assessment whether to cool or not, and also not to change the CFM trace. But after we made a decision, we started some morphine. So what's happening for this baby at the moment? We have two things happening. We have HIE, right? What HIE can affect in terms of respiratory and hemodynamic, it can cause increased peripheral vascular tone. So it can increase SVR, especially with active cooling. You will have this. Can also cause bradycardia. So cardiac output will be reduced. And can affect the, can cause pulmonary vasoconstriction with catecholamine release and increased blood viscosity from the cooling as well. All of which will cause increased PVR. So we have increased SVR, reduced cardiac output, and possibly increased PVR as well. And we have hypoxic respiratory failure by definition, because FI2 is more than 60% to maintain SATs above 94. And also we have CO2 clearance difficulty. So we have VQ mismatch, which is leading to hypoxemia. We have hypercarbia, increasing PVR. We have also the increased PVR can cause increased RV afterload and can eventually lead to RV failure. And RV failure, because of interventricular dependency, we know that can cause LV failure as well if you leave it untreated. So it was a bit complicated. So what can we do for this? What do you think is the best approach for this one? Again, Abjit, Becky, and Fraser, I'm gonna pick up on you three of you today. Hope you don't mind. So if you are in the neonatal unit during your on-call, what you're gonna be your strategy to manage this baby? Starting from the top, ventilation.
Yeah, Mahmoud, I think we have started already on high frequency for your CO2 clearance, and for your hypercarbia, so hypoxia, you are going up on the higher FiO2 levels. So in terms of your the RV failure, progressing to LV failure, or increased PV or increased RV afterload.
Well, we don't know that's the case. We assume this is the case. So would you like to do something just to find out?
So, yeah. So I mean, theorizing that we would need to have a look at the heart, basically.
Exactly.
So here comes the point of care echo to access the left and right ventricle.
Yeah, absolutely, Abjit. That's correct. So I'm just gonna. So let's talk a little bit before the echo. Let's talk a little bit about assessing the severity of HRF, hypoxic respiratory failure. So if you work out the OI, it was 18, right? So we know the equation of OI, so I'm not going to go through this. There are other parameters which not quite often we use, but I think it's useful to have more information and kind of confirming your assessment. So there's something called oxygen saturation index. It's similar to the OI, but it's essentially you're dividing the MAP, mean airway pressure, multiplying the MAP times the FiO2 divided by SpO2, and that was 10. And I will show you the grades in the next slide. And then you can work out your alveolar arterial gradient. So essentially, if you have a normal lung with normal diffusion, you should have the difference between the alveolar oxygen content and the arterial oxygen content shouldn't exceed 10. However, if you have any diffusion problem, then you need to work out what's happening. So when you work out alveolar partial pressure of oxygen with the equation that you have here, was quite high. It was 352. So oxygen in the lungs is high, but it's not coming to the blood because of diffusion issues, because of the significant VQ mismatch. So that's again giving you indication you need to work on your lungs. And then when you look at saturation FiO2 ratio, it was high again. So I will just show you the table, makes more sense. So this is modified actually from the reference below here. And when you plot all your markers, you will find that, so it should be moving up a little bit. So AA gradient above 100, that's severe. Oxygenation index above 15, again, severe. And then oxygen saturation index above 7.5 and saturation FiO2 ratio below 180. You can actually work out the right to left shunt. There is something called oxygen reduction test, and there is a centile equation with calculator online. You can, so the oxygen reduction test is essentially stand beside the baby and reduce the FiO2 by 2s every 1 or 2 minutes and look at the saturation. And then you plot the FiO2 saturation and your hemoglobin on the curves, and it will work out for you how much right to left shunt. Obviously, if it is less than 10 is fine, 10 to 20 is moderate, more than 20% is severe. And that reflects the degree of VQ mismatch as well. I didn't do that because I just simply didn't have time to do that for this case. But if you want, you can do that. And also you can look at oxygen saturation histogram on the monitor as well. Okay, so what shall we do now? So as you said, Abjit, we're just gonna do echo. So this is a kind of 4-chamber view. You expect with the cooling effect, the heart rate will be slightly low, the contractility will be slightly slower. But we can see here the RV is dilated, septum is flat and desynchronous. But overall, contractility is okay by just eyeballing. And when you put color on, you can see good going to TR-jet. And then here, maybe possibly there is a bit of MR at the end of the loop, but let's do a quantitative assessment and see. This is a parasternal long axis. Again, contractility here probably is not brilliant. And this is the duct, looks bidirectional, and that's the Doppler for the duct. And then looking at mitral valve inflow, the EA ratio was 0.9, and the tissue Doppler for the mitral valve as well, sorry, the left free wall was done, and this was the conclusion. So dilated RV with flat septum, moderate PDA with bidirectional flow, TAPSI was 0.8, which is low for a term baby. LV S wave was 3.1, that's reduced for a term baby, and the EA ratio again 0.96, indicating reduced diastolic flow, reduced diastolic function. Calculated LVO 137, which is low, and we know cooling can cause that, and RVO was okay. Systemic vascular resistance was high, which again we know that cooling can cause that. But and then oxygen delivery, you can calculate that with the by plotting the hemoglobin and using the formula with the cardiac output and the baby's weight, and the normal is 20 mils per kilo per minute, so this was very low. And again, this was a kind of the blood pressure at this time. So echo, in summary, showed evidence of pulmonary hypertension and slightly reduced both systolic and diastolic function with high SVR and reduced oxygen delivery. So what can we do for this baby now? If anyone want to comment. Okay, so we top the baby up, we give him some top up just to increase oxygen carrying capacity and improve the oxygen delivery. We started dobutamine at 6 mics, simply just as to work both as inotropic support, improve the contractility, and also cause a little bit of peripheral vasodilatation to reduce the SVR. I didn't use any dopamine because dopamine in the setting of HIE and pulmonary hypertension actually is not the best drug. It causes increased peripheral vascular resistance, and it doesn't give you that. This actually can cause also tachycardia, especially if more than 10. And definitely you don't want to cause tachycardia for this baby and increase oxygen demand on the heart. We continued in high frequency. We didn't start nitric because I'm sure people thought of nitric, and I did as well. But because of the diastolic function of the LV, I didn't start nitric at the moment. I wanted just to improve function first and then put the nitric after that. And we were really struggling with lots of secretions, and SATs were kind of dropping occasionally between 88 to 93, and oxygen was still static like 63. So baby was kind of not very synchronous, so we decided just to give him a bolus of muscle relaxant, and we did a lung ultrasound just to see what's happening with the lungs that actually started off very poor chest X-ray. And the lung ultrasound revealed areas of consolidation collapse, mainly on the lateral and posterior lung zones. I'm just gonna quickly show you. It's not the best pictures because this baby was tricky to scan. But you can see here, this is the right upper lobe. You can see large area of consolidation at the top here, and coalescent B lines. And then in the right lower, wasn't too bad. Actually, pleura is sliding, A lines, no major consolidation collapse. And then the right posterior, you can see these are the ribs, and the pleural line is completely interrupted with large area of consolidation here. And then left side, left upper actually wasn't too bad. Left lateral showed area of consolidation, and then when I put the probe on the back, I just tilted the baby because obviously I couldn't completely put him prone, and you can see here areas of consolidation, and the pleura actually is not seen. So what we decided to do then is just to try to use the open lung strategy on the high frequency to recruit the lung, which sometimes we do for babies with MEC aspiration. So I just sat standing beside the baby and kept going up on map by 1 every couple of minutes until I reached 18, and then suddenly SATs improved to 96, 98, and FI2 I was able to wean down to 45. Blood pressure remained stable, and all his OBS were stable. So we decided just to leave the map on 18 because that has opened the lungs. And these are the X-rays. You can see this is before. The one on the left hand side, very patchy, poorly recruited lungs. And this is the one after opening the lungs with map of 18. And you can see it's much better, although there are still areas of consolidation, but definitely much better. So at that point, we managed to open the lungs, and CO2 started to come down nicely, continued on dobutamine, blood pressure remained okay, SATs fine. And then we commenced the nitric at that point, because first we opened the lungs because you don't want to use the nitric with high VQ mismatch. The nitric will go to selectively to open area and bypass the recruited area, increasing actually your VQ mismatch. And second, we wanted to start the nitric after improving the function of the heart, because if you have LV dysfunction and you start nitric, what will happen is you're gonna increase pulmonary venous return to the LV who's failing, and that will increase the pressure on the left side and cause back pressure and pulmonary congestion in the lungs. So you don't want to do that. And then subsequently, FI2 started to improve, came down to 30% by the end of the day, and next day to 21%. Gradually weaned, and the high frequency dobutamine, the same, weaned and stopped, and then nitric start to wean, and they went down to 13. So the team continued to look after this baby. I just finished my weekend, I left, and then muscle relaxation stopped, switched to SIMB, and everything seemed to be going the right direction. So day 4 to day 5, FI2 started, so that was like after rewarming the baby, FI2 gradually going up to 75%. And these were the settings, and pre-ductal SATs 96, post-ductal 88. Blood pressure actually is okay, acceptable gases, lactate is fine. And the baby was switched to Vanc and Kef because CRP just went up a little bit to 20. So what's happening here? So they thought the baby pulmonary hypertension has become worse because you could see difference between pre and postductal SATs. And for that reason, they decided just to go up on nitric, which is fair. FI2 remained 70. And then they've repeated that chest X-ray. Okay, so this is a chest X-ray. You can see, again, quite patchy. It looks like there is evolving right upper lobe collapse, with lower lobe as well as quite patchy. Left side is patchy. And then the suction the baby, puts right side up, open a little bit, but there is a small kind of middle lobe collapse as well. Left side looks better. So there is, so I would say X-ray is improving, if that makes sense. So they started, because nitric didn't actually seem to work, they started weaning, and I will talk about that in a minute. So they gradually went down to 10. FI2 slowly went down to 60. Blood pressure is, as you see, CRP jumped from 18, was like to 20, and then 42. So reculture added gent and decided to remove the umbilical lines because we thought that might be line associated sepsis. And then second echo performed. So what do you, any thoughts about what's happening with the baby? Okay. So we did another echo, just see what's happening. Right, so this is a 4-chamber view. Heart contractility looks better, probably more, I would say a bit slightly hyperdynamic compared to the one when the baby was cooled. Again, septum is still flat, slightly desynchronous. And this is the left ventricle inflow, and you can see a good going mitral regurg. And the left parasternal parasternal long axis view, you can still see as well a good going mitral regurg here. And when we measured, you know, the PAT and RVET and the TRJET and all these kind of things, so we came up with this conclusion. So actually the mitral regurg was 4.3 meters per second. The TRJET was 3.1, is estimated about 45 to 50. And sorry. Just move this 1 second. Okay, let's go back. Right, so the pulmonary venous D wave, so pulmonary vein Doppler was 63. That's high, indicating pulmonary venous return is increased to the LV. The inflow EE wave ratio was 0.96, TAPC was 0.8 still, and the TDI was done, and this was the conclusion. So it was a small closing PDA, left-right flow, TRJET, as mentioned. PAT was still short with RVET and ratio of 0.26, indicating still there is ongoing pulmonary hypertension. TAPC borderline, so it actually didn't improve much. And we know that dobutamine was stopped. MRJET of 4.2 meters per second. Pulmonary vein D wave was high. The S prime is 4.7, borderline, but the EA ratio indicated moderate diastolic dysfunction, because the E prime is early diastolic and A prime is late diastolic, and both actually were borderline, indicating there is a degree of LV dysfunction, not coping with the increased pulmonary blood flow coming from the lungs. LVO was borderline, RVO was okay, and SVR was high still. So probably the conclusion is that because of the increased SVR, there is a degree of LV dysfunction, but that was aggravated and worsened by the nitric. So when you use nitric in the setting of LV dysfunction, that what happens is just overload the left side, which eventually fail. And if you don't wean and stop the nitric, this will continue. So what we've done at that point, I was just coming to my own call, and what we've done is we just stopped the nitric completely. I didn't even wean. I stopped and started dobutamine and remained ventilated. And that was Friday evening. So we kept the baby ventilated. Oxygen came down to 30% by the night time. And then next morning, I scanned him before I leave to the weekend team, and oxygen came down to 23. So recommended just to leave the dobutamine over the weekend, and we scanned him again on Monday. And that was the scan on Monday. So you see more relaxed heart. Again, the septum is still a bit flat, but you can see probably is bowing to the right side at the end of systole of the LV, and the MR is almost completely disappeared. And this is the short parasternal axis. You can see again slightly rounded LV, not completely flat. So that septum is better. And PAT was 88. And the LV was the TDI was much better. So no MRI seen, PDA closed, TRZ 2.1 is much less. Ratio of PAT over RVET is 0.4, TAPSI 1.4 normal for a term baby. And the TDI actually is much better. And the ratio was 0.7. So baby was extubated then and to high flow, which was weaned very quickly to air subsequently. Neurological assessment was very reassuring. Baby actually is sucking all her feeds, and she's going for MRI today. She should have had it by now. So just, I like this infographic. So it just simply explains why we have issues when we have LV dysfunction and use nitric. So probably we were in this stage with the LV dysfunction, and when you add nitric, it just doesn't work. But we don't have, luckily, we didn't have severe pulmonary hypertension causing RV dilatation at that point, and that's why we didn't require to use Prostin to reopen the duct. So there are quite nice articles actually for our senior trainees, if you like to have more reading about hemodynamic optimization in hypoxic respiratory failure and HIE. I would recommend these two and this one as well. So yeah, so that's the case. I'm happy to discuss further if you have any questions. Yes, Nim.
Hi, thank you very much, Mahmoud. Really interesting case. My question was how you assess LV function and what's your preferred method? Obviously, you use tissue Dopplers to assess LV function, and I think you looked at the mitral valve EA ratio. Could you comment on different methods and why you would choose one over another?
Yeah, sure. So we use kind of all the standard methods. So I use fractional shortening, which I didn't include in the parameters, but we use that. we use the systolic assessment with strain as well. But the problem with the machine I'm using, which is Samsung, is not a cardiac machine, and their strain is not designed for pediatrics. So the width of the envelope is very thick, and when you start to align it yourself, it just increases the error. So I stopped using strain. But this is another way of assessing LV dysfunction. You can use strain and strain rate to assess the LV function. The tissue Doppler is quite nice, and the S wave reflects the systolic, and then the EA reflects diastolic. So you can actually, with tissue Doppler, assess both systolic and diastolic. And there are reference ranges available. Afif has devised a nice manual. I put on the WhatsApp group earlier. I can email it to the group again. There are reference ranges for preterm and term babies. You can use just to compare, and you just put all together in the clinical context and just make sense in the end. What do you use, Nim?
Sorry, amongst the group, we don't really have a standard way of doing it. And we're not quite as sophisticated as you guys in terms of measuring strain and that sort of thing. Probably Simpson's ejection fractions would be the most popular. I suppose another question might be, why would you choose dobutamine versus, say, low-dose adrenaline? We're like you, for simplicity, we tend to use dobutamine as our primary inotrope, but I'm sure others would choose adrenaline. Have you got a view on one over the other?
Yeah, adrenaline actually, I know adrenaline would probably be the first choice because with the lowest systolic, so this baby had actually selective systolic hypotension. So it didn't have, the mean was fine, but the systolic was low, and the mean was fine because the diastolic was high. So if I use low dose adrenaline, I thought, okay, it might help the contractility a little bit, but won't help the systemic vascular resistance. It won't reduce it for me. And I wanted just to reduce it a little bit to make it, because, with the high SVR, especially if I'm gonna go up on adrenaline, if people start winding up adrenaline to 0.1, 0.2, that will even make it worse. And I was conscious that you're not around 24/7 in the unit, and some people simply can just when the blood pressure start dropping can go up on adrenaline, and that will make things worse. So the reason and rationale for dobutamine was two things: inotropic support and also vasodilator to reduce the SVR.
Hi, Zoltan's here.
Hi, Zoltan.
Hi, thanks very much. Absolutely super presentation. We had a case recently where they started nitric without echo. Baby had pulmonary hemorrhage, pretty similar to your case, and probably the mechanism was as you described. Does that mean that, and I'm asking Nim and the others, that in your hospital, nitric is not started without echo to prevent what you've been talking about, and that might have prevented the pulmonary hemorrhage in our hospital recently?
Yeah, I mean, that's a great question. And the simple answer, I don't know. But I personally with echo, but I know that wouldn't be possible in every setting.
That's the question.
The problem. And I don't know, what do you think, Nim?
Yes, I'm like you, Mahmoud, that if it was me, I think that's the gold standard. We should be doing echoes before starting any pulmonary vasodilators and probably any cardiovascular support, full stop, but certainly nitric. Our guidelines say that in extreme preterm babies in particular, we should do an echo and demonstrate an extra pulmonary shunt before we start nitric, because that's the way that we restrict our nitric use. For the babies who are most likely to respond and in whom there's best evidence for its use. So if there wasn't evidence of PPHN and you had just hypoxemic respiratory failure in an extremely preterm infant, we wouldn't use nitric in that situation. But as everyone knows, we don't have echo expertise around the clock, and there will be instances, quite a few instances, where nitric is started both in term and extreme preterm infants without a baseline echo. I wouldn't want to do that, but when how do you avoid that without having the benefit of some sort of echo team that's going to be on tap 24/7, which I don't think anyone has.
Oh yeah, that's the problem.
Yeah, but I suppose what we can do is just use some clinical parameters, and like if you have obviously pre-post ductal gap, that's a clue. There is a pulmonary hypertension, and if the nitric, if you're going to start nitric without echo, and if you didn't see a response, I would just back off because I think it's going to probably cause more harm than benefit. If there is pulmonary hypertension, you will see instantaneous response to nitric, and that would be encouraging to continue and probably wean after that. But if you start nitric and there is no response, then there is something wrong. Either it's not pulmonary hypertension, or either there is LV dysfunction, and you definitely don't want to continue on nitric.
Yeah, so it would be a good clinical marker to assess the LV dysfunction, isn't it, without an echo? So that's what we would like to prevent, but there might be some improvement, but if it will just overload the heart, and then probably a poor systolic function by just measuring the blood pressure might be something what clinician can
exactly
and be a little bit more careful when, rather than just start the nitric because the baby's FiO2 is more than 6 and there is pre and post ductal saturation difference.
Absolutely, and use the pulse pressure as a guide as well, because if you have a narrow pulse pressure, that's a bedside indication of
poor systolic function.
Yeah.
Okay.
Abdul, and then Sajid.
Yeah, Mahmoud, I just wanted to ask about your experience with vasopressin in situations like this. With claimed effect on pulmonary vasodilation and reduction of the back pressure, translating to improve RV diastolic function.
Vasopressin, you're saying, isn't it?
Yes.
Yeah, so vasopressin is widely used more probably in PICU settings. We don't use it very often in neonates, although it started to gain more popularity in North America. And they have published quite few case series about the use of vasopressin in refractory pulmonary hypertension. But I probably want to use it in the setting of resistant hypotension with pulmonary hypertension, because eventually the mode of action of vasopressin, it's a pure vasoconstrictor, so it will improve your SVR, right? So I probably don't want to use it in this baby because you already have high SVR. And if you increase it even more, you will increase the afterload on the straining ventricles, if that makes sense. So it's not going to help in this setting, but yes, vasopressin, I think, is gaining more popularity in resistant pulmonary hypertension. It increases SVR, and some people claim it also reduces pulmonary vascular resistance. That's kind of double impact. But if you have already a baby with increased SVR, you want to reduce it rather than increase it, if that makes sense.
Yeah.
Sajid?
Hi, Mahmoud. Thank you so much. Great case. One of the things I wanted to sort of emphasize is I second your point on LV dysfunction when you don't have echo service at hand. And I know non-responsiveness is a red flag for me for two reasons. One, because of LV dysfunction, and also, is there an underlying structural heart disease? From the case, I had a couple of questions. One was, once this baby was rewarmed and you had nitric started, and now that the baby is not being cooled, would you have considered milrinone to help with the LV dysfunction?
Yeah, that's a perfect question. Actually, it did cross my mind. Obviously, I wasn't around during this period, but then when I came on call, the UAC was removed already. and the baby was still on high oxygen requirement. But I see the rationale. They had to take the umbilical lines out because of the possible sepsis. And I didn't have arterial access at that point. I wanted to start Merinone, but I was worried that might cause severe hypotension. So I thought we'll start something that might work, and if it doesn't, then we'll move to Merinone. So it did cross my mind because it does act as a inotropic support. Actually, it's a lusitropic and also reduces the pulmonary vascular resistance. So it can help you both ways. But yes, Merinone would have been a nice choice at that point if you have full monitoring facility available.
Yeah, and just following up on that, another question is, in the context of HIE, have you come across, I know we've come across situations where we've had difficult oxygenation because of cooling.
Yes.
And I know on instances we've all had to sort of sadly stop the cooling, but one of the things I wanted from you and from this group is, have you come across situations where for a transient short period, you sort of increase the cooling temperature threshold? So I'm not saying to go above 34, but say, for example, if you're in 33 degrees, you go up by 0.5, or you go up by 1 degree to 34 transiently for a few hours to try and reduce the pulmonary vascular constriction and sort of improve your oxygenation. Have you come across that practice, or what do you sort of personally do when you're stuck with the difficult oxygenation?
Yeah, I've heard about this strategy from other colleagues. I personally haven't done it myself, but on the other spectrum, I have seen babies cooled and on ECMO. So I suppose you don't want to lose the benefit of cooling and prevent the secondary brain injury. And you're just trying really to keep the balance. I know it's sometimes very fine balance and sometimes it's difficult. And I agree, I've heard some cases they had to completely stop the cooling because it's just not possible. But yeah, I don't know if reducing, like increasing temperature slightly would help to improve the hemodynamics and improve the pulmonary hypertension. But what would be the impact on the HIE itself? I don't know if any of the audience would like to comment on that. But that's a very good question.
We only stop cooling if it's kind of life-threatening circumstances, because we think the neurodevelopment is so prior. Sometimes we do, but only if there is life-threatening pulmonary hypertension and we are just unable to get on top of the things. So that's our practice.
Yep.
Thank you.
And I agree with you about Merinone during cooling because it's quite tricky, and you have to be careful, especially if you have associated AKI, because it's excreted by the kidney and the half-life is quite prolonged. So and again, if I'm going to use Merinone during cooling, I probably will just stick to the 0.33 mic per kilo rather than going to 0.5 and 0.7. And you will have more side effects, definitely. Okay, any other questions? Okay, thank you very much, everyone. Anyone would like to present next week or week after? If you have interesting cases, please feel free. You can text me.
I feel at some point we will present, okay? We had a case a couple of years ago when we started vasopressin, which resulted in a really miraculous improvement. And I'm happy to present that case, if not next week, the week after, okay? Because I'm on clinical service next week.
Yeah, that would be amazing. Thanks, Dalton. And if you would like, also, it would be great if you please can share your monograph with us as well, because we're still in the process of creating a monograph for vasopressin. That would be great. Thank you so much. Okay, thanks everyone. See you next week.
Thank you, Mahmoud. Thank you.
Thank you, Mahmoud.
Bye.
Thank you.
Thanks, Mahmoud. Bye-bye.
Bye.